Good evening, everybody. Thank you so much for being a participant here today. So as we all know that we have started a webinar series. We would be having a webinar based on renal nutrition every month. And this is the second webinar which we are having for the year 2024. It's a privilege and honor to have Dr. Mukesh Shetty and Dr. Priya Chitle amongst us. The convener for the session today is Dr. Chafekar. Sir does not need an introduction, but still I would like to introduce for everybody. So Dr. Devdutta Chafekar, as I said, does not need an introduction. Sir is the premier kidney specialist. Sir is on his MD medicine and DM nephro and DNB medicine. He's on his DNB nephrology and has a lot of fellowships to his accolades. He's an experienced nephrologist with a work experience of more than 3 decades and is a consulting nephrologist with Wokhad Hospital, Shayadri Hospital, and a professor of medicine at Dr. V. Pawar Medical College, Namsek. Sir is the director and chairperson for Renal Nutrition India, which is an IPN core group and is looking after the renal aspect of the nutrition. Sir is also the editor for Health and Healthcare Medicine, IVTR. He's a member of the Indian Society of Critical Care Medicine and Indian Society of Nephrology. Sir has many publications to his name and has been rewarded with various awards, including fellowship awards. And he has significant posts in various associations, apart from presentations at several national conferences. It's an honor to have you here, sir, as a part of the IP and RM group. Thank you so much. Sir, can you introduce?
Yeah. So good evening, everybody. It's a pleasure to have Dr. Mukesh Shetty for this webinar. He is a friend of mine since many years. He's a senior consultant nephrologist at Jupiter Hospital, Thane, Kimaya Kidney Care Center, Thane. And as I was telling everybody just a few minutes ago, that Mukesh is a multifaceted personality. He's an extremely accomplished teacher, and he has been teaching MBBS, MD students, including all the nephrology fellows for a very long time, especially at Sion Hospital. Then he's attached to so many hospitals in Mulund, Thane area. And he just told me that he's also looking after a multi-speciality hospital in Mulund. And he's also attached to Jupiter Hospital. And I have personally seen the Kimaya Kidney Care Center at Thane, and it is extremely well managed. Mukesh also manages a chain of dialysis centers in Pune and around. And I think that it's a pleasure to have him. Whenever I have requested him for some task, he has never refused. And I'm sure that from his talk, you are going to have a lot of take-home messages. And I once again thank him for accepting this invitation and, sharing his knowledge with all of us.
Thank you, sir, for those flattering remarks. Should I upload these slides?
Yes, sir.
So I hope it's visible. Is the slide visible? Yeah.
Yes, sir. Yeah.
So in the next maybe 20-25 minutes, I'm just going to talk to you about metabolic acidosis, mainly with the nephrologist perspective. So let's first talk about normal acid-base balance. Then probably we'll be able to learn the nephrological aspects of acid-base balance and then its application clinically. So when you talk about acid-base balance, there are some definitions. What is acid? It's a group of H ion containing substances that dissociate in solution to release free H ion and anions. So for example, we have H2CO3, which is a carbonic acid, and it will dissociate into H ion and HCO3. That is a bicarbonate ion and H ion. And because it is able to release free H ion, it will be called as acid. Similarly, we have bases which are able to combine with free H ion and remove it from the solution. So bicarbonate certainly can combine with H ion and can form H2CO3. That is how it will be able to remove H ion from the free H ion from the circulation, and that is why it will be bicarbonate would be taken as a base. Now, this is the definition of pH, which is nothing but negative logarithm of H ion concentration. pH 7 means it is neutral, less than 7 is acidic, more than 7 is basic, but that's the biochemical definition. When you extrapolate to human being, then the average pH is considered as 7.4. If pH drops down below 7.4, it will be acidosis. More than 7.4, it will be alkalosis. And up to 6.8, that is the maximum lower side of the pH which a body can tolerate. And then mortality is the usual outcome when the pH is below 6.8. Similarly, when alkalosis is not something normal phenomena, if your pH goes up beyond 8, it has the capacity to create a lot of changes in the body, including cardiac arrhythmias and death. And that is why alkalosis extreme as well as acidosis extreme both are dangerous to the body. And that is why it is important to maintain the pH at 7.4 or in and around 7.4, and body will try to do that maximally. So, what are the body sources of acids and base? So, we have two types of acid. When you say acid, that means they are H ions. They are volatile acids and non-volatile acids. So, when you talk about volatile acid, it is basically carbonic acid, which we just saw, because that is able to dissociate. The definition of volatile acid is some acid which is able to dissociate. Non-volatile acids are fixed acids, like which are produced during breakdown of nutrients like sulfuric acid and phosphoric acid, and even lactic acid, which is often a result of anaerobic metabolism, and it is a conversion from pyruvic acid into lactic acid because of less oxygen milieu, and that's the usual type of acidosis seen in septicemia and septic shock. So these are the non-volatile acids. And now whenever there are acids, naturally these acids are consumed or they are being utilized by buffers, because unless you do that, you'll not be able to match with the free acidic milieu into the body. Otherwise, body will get acidemia. And these buffers are important and they are called as chemical buffers. The utility of chemical buffers is they can function almost immediately. As soon as something goes wrong in the body and the pH turns acidic, these buffers come into action within seconds and minutes. Why there will be another system by which your pH will be brought back to normal, and that is respiratory mechanism. Like when you hyperventilate, actually what you are throwing out is CO2. But when you are throwing out CO2, it is as good as you're throwing out H2CO3, because CO2 was there in the body to form H2CO3. So in short, you are actually exhaling out acid, and that is how you'll correct acidosis, because it will be thrown out from the body. The renal mechanism would take hours to days. So in minutes, chemical buffers, in maybe minutes to an hour, respiratory mechanism, that is by CO2 washout, and renal mechanism will come into action in hours to days. And all three would probably try to create a defense mechanism against the pH change and try to maintain the pH at the stable level, that is around 7.4. So these are the chemical buffers which we have. So one is a carbonic acid, which we just saw. It's primarily an ECF buffer, that is, it is there in the extracellular fluid, and it mainly acts against non-carbonic acid changes. We have protein buffer, which is primarily an ICF buffer, that is intracellular fluid, but also can buffer extracellular fluid. Hemoglobin acts as a big buffer, and you know there is circulating blood almost of 5 liter into the body, that is your circulating volume, and that primarily buffer against carbonic acid changes. And phosphate buffer, which is predominantly active in the kidney, and that is an important urinary buffer, and that also buffers the intracellular fluid pH changes. So buffer system do not eliminate HI form or add them to the body, but only keep them tied up until balance can be re-established by other mechanisms. So that's why they are in action within minutes, but they'll not allow free H ion to accumulate. So remember, if free H ion accumulates, your pH is rapidly dropped, and it can drop from 7.4 to 7 in no time, and 6.8 is the limit where mortality comes. And that is why the immediate action is important. So they do not allow H ions to be free. Meanwhile, your respiratory system takes over, your renal system takes over, and your acidosis is corrected. So that's why there's a undue importance given to the buffer system of our body. So buffer system in the body, most important is the bicarbonate. Whenever there's the free circulating water combines with the CO2, which is the end product of many metabolism, that will combine to form H2CO3, and we have H and HCO3. Then we have phosphate, which is important ICF and renal tubular buffer. and HPO4 2 minus can combine with 2 units of H ions and it will form H2PO4. So one HPO4 unit is able to consume 2 ions of H hydrogen, and that is how it is considered as a big buffer. Ammonia, which is NH3, can combine with H ion in the renal tubules and can form NH4, which is ammonium. So when you have ammonia into the renal system, it will accept H ion and it will form ammonium. And proteins which are freely circulating into the ICF and ECF, especially the most important protein is albumin, globulin or hemoglobin, and these proteins will also act as a buffer. So these are very important buffer systems into the body. So in fact, the importance of buffer system is further established here by this slide. What it shows is that there is normal H ion concentration, which is 0.0004 millimoles per liter. Okay, or it is considered as 40 nanomole per liter. And the amount of non-volatile acid produced is much higher, that is around 80 millimoles per day. That means if I consider 80 millimoles per 42 liter of the volume, then it comes to 1.9 millimoles per liter. So this is 47 5,000 times more normal H ion concentration, and that we do not see as free circulating H ions simply because it is buffer system. If that would not have been there, the H ions would have been concentrated into large amount and it would have created almost life-threatening metabolic acidosis. But that doesn't happen mainly because of this buffer system. While respiratory system, we know that it regulates the pH by the rate of carbon dioxide removal. So these type of changes would occur when there is respiratory adjustment to acidosis or alkalosis. So once there is normal pH, your ventilation is normal, the rate of CO2 removal is normal, rate of H2CO3 formation is normal, rate of H ion generation from CO2 is also normal. But as soon as there is metabolic acidosis, the ventilation will go up so that the CO2 is washed out. That means CO2 is removed. H2CO3 formation also would decrease and H ion generation will also decrease. And if there is alkalosis, reverse would happen. Ventilation will slow down, the CO2 removal will slow down, H2CO3 would be formed more because there is more CO into the blood now, and even H generation from CO2 would go up because H2CO3 will convert into H ion and HCO3. So there is a compensatory mechanisms at the respiratory level whenever there is either metabolic acidosis or alkalosis. And as long as it is compensated, you label this acid base disorder as single. That means there is metabolic acidosis with compensatory respiratory alkalosis. So that is the usual compensatory mechanism. But for any reason, if it is not compensated, that means you have metabolic acidosis with either unexpectedly low respiratory alkalosis or high removal and more alkalosis, then it will be termed as double disorder. So these are some of the disorders which are important from clinician's point of view, because accordingly we can judge the etiological factor leading to this problem. But as long as the metabolic acidosis is concerned, you have a compensatory mechanism at the respiratory level. In fact, today's talk was mainly to talk about nephrological perspective, and I'm going to spend some few slides just to understand the role of kidney into this acid-base balance, and that's the third most important defense against change in hydrogen ion. But it requires hours to days to compensate for changes in body fluid. The control of pH of body fluid by kidney is by adjusting H ion excretion, bicarbonate excretion or reabsorption, production of new bicarbonate and ammonia. These are the four pillars which are handled by kidneys in order to maintain the acid base balance. So the blue line, no, the blue bracket just shows that what are the areas which probably are thrown out from the proximal tubule. That means they are absorbed back into the bloodstream. So glucose is absorbed back into the bloodstream by the proximal tubule. Amino acids are absorbed, proteins are absorbed, vitamins, lactate, urea, uric acid, and what is it? Into the tubule. What is going into the tubule is H ions, the NH4, and creatinine, uric acid, and urea. So accordingly, this will be thrown out and this is reabsorbed. And this occurs not only in the proximal tubule, also in the distal tubule, also into the collecting duct, and these various porters, which are there throughout the tubular lane are actually responsible for maintaining the acid-base balance. So naturally, this is not so easy to understand, but I am just trying to give you few key slides to understand what is the mechanism by which the kidney play a role in acid-base management. So there is a porter called as sodium hydrogen exchange porter into the proximal tubule, whose role is that sodium would be reabsorbed. Again, sodium, which is a positive cation, if it is absorbed, to maintain the electron neutrality, H ion will be thrown out. The HCO3 dissolved into the lumen will combine with H ion to form H2CO3. H2CO3 will be converted into CO2 in H2O. This is by an enzyme called carbonic anhydrase. This free carbon dioxide and water is reabsorbed into the proximal tubule. This is action called as carbonic anhydrase 4, and this is carbonic anhydrase 2, which will reform CO2 H2 into H2CO3, and bicarbonate is reclaimed into the blood, and that goes back into the blood. So sodium is absorbed, bicarbonate is absorbed, H ion is secreted. This is how your H ion secretion maintains the luminal acidity, and the bicarbonate reclaim into the body, that is in the blood, will maintain the pH of the blood. And that is how we do not allow any bicarbonate loss across the proximal tubule, and nearly 99% of bicarbonate is reabsorbed. While H ion secretion is also a unique property of the kidney, and that is mainly because of these two pumps, hydrogen ATPase and sodium hydrogen antiporter, and they basically would be responsible for active H ion secretion into the tubulumen. This partly happens into the proximal tubule, but mainly happens in the peritubular capillary lumen of the distal as well as into the collecting duct. So this is an active transport. That means it is just an energy derived push out of H ions into the tubular lumen, and by secreting H ions into the tubular lumen will increase the tubular acidity, but then that is how you will be throwing out all your extra acid from the body into the tubular lumen. So whenever there is more metabolic acidosis, there is more throwing out of H ion into the tubule and lost into the urine. Whenever there is more metabolic alkalosis, this H ion loss is conserved and it is not allowed to be wasted. This is how the distal and collective tubule H ion secretion would be able to maintain the pH of the blood. So there is H ion secretion and excretion, which couples with the bicarbonate reabsorption or reclamation, and that is how you are actually going to maintain the pH. The other urinary buffers which are also active into the urinary system are mainly HPO4. We saw that HPO4 accepts two H ions and that forms H2PO4, and the ammonia NH3 combines with H to form ammonium, and both these will also be acting as a buffer into the urinary system so that there is no free H ion circulating into the tubular lumen. See, the urinary pH can drop down as low as up to 4.5, but not below that, because if your urinary pH falls below 4.5, that means urine becomes too acidic. It's almost that the acid is urinated. That is mainly because there is more metabolic acid in the blood, and the kidney is given that task to excrete all that acid. Naturally, it will do so with its maximum capacity, and it will try to bring down the pH as low as 4.5, or even sometimes at 4 or 3.7. But while doing so, the renal medulla is exposed to severe acidosis. The renal medulla is exposed to highest H ion concentration into the tubular lumen, and that is detrimental to kidney. So why metabolic acid is not too good for the body is, though kidneys are supposed to compensate, but when they themselves are exposed to highest excretion of H ion and highest acidic milieu into their tubulomedullary compartment, then they get damaged. And that is why you have to maintain the metabolic acidosis, okay, by some mechanism, so that kidneys are not given undue task so that they themselves get damaged. So the renal responses to acidosis and alkalosis are that in acidosis, your H ion secretion will increase, H ion excretion will increase, your bicarbonate reclamation would improve so that the pH would become more and more acidic. While in alkalosis, pH also becomes more and more alkaline because you are actually conserving H ion into the blood and not allowing it to get lost into the urine. So that's how you are basically actually going to maintain this mechanism. So in short, whenever you have acid base disorder, the question is whether the pH is less than 7.4 or more than 7.4. If it is less than 7.4, you call it as acidosis. More than 7.4, alkalosis. And you're always keeping in mind, is it metabolic or respiratory? And if there are already compensatory mechanisms, it becomes a single disorder. If there are not compensatory mechanisms in hand, then it will be called as double disorder. So this is a metabolic acidosis example where if your bicarbonate is as low as 10 and the log of CO2 is 1, then the pH is 7.1. That means despite CO2 loss, your pH is acidic, so this is not compensated. While here, bicarbonate is 15, but the CO2 is further reduced and adjusted the pH to 7.4. That means this is a compensated mechanism. So compensation is basically by a proper buffer action. Lungs blow out additional H ion generating CO2, and kidney excretes more HIN and consume more bicarbonate. That is how there will be a compensated metabolic acidosis. So metabolic acidosis may develop due to loss of bicarbonate, dilution of addition of exogenous or endogenous acids, retention of HIN due to impaired renal function, or diminished NH4 production. And usual common causes are lactic acidosis, renal tubular acidosis, ketoacidosis, diarrhea. These are the clinical situations where you get metabolic acidosis. So either loss of bicarbonate, that's mainly going to happen in renal tubular acidosis. Dilution of acids, that is going to happen when there is exogenous intake of salicylase, or there is exogenous intake of acids like methanol or ethanol, and that will dilute the acids. Retention of HIN due to impaired renal function, which is actually going to happen because of CKD when the GFR goes down. Diminished NH4 production is because of abnormal tubular mechanism, or again a renal injury where you are not able to reclaim the ammonium into the renal system. So these are the mechanisms by which you will get metabolic acidosis. One more concept of acidosis is anion gap. And what do you mean by anion gap? That you have basically sodium plus unmeasured cations. Then you have chloride and bicarbonate as negative, that is anions, and unmeasured anions. So on one side you have all cations, on one side you have all anions, and ideally when you list them, your electroneutrality should be zero. No, your all net anions should be equal to net cations. But because you are not able to measure all the anions, okay, that is why that gap comes. Because okay, when you are measuring, the principal cation is sodium, principal anion is chloride and bicarbonate, but there are still some unmeasured anions which remains, which are mainly sulfates, phosphates, okay, albumin, proteins, and that's how this anion gap comes. This is more like a concept, but a diagnostic concept for many situations. So I'll just elaborate that anion gap is sodium minus bicarbonate or venous carbon dioxide plus chloride, and the unmeasured cations are potassium, calcium, or magnesium. Unmeasured anions are albumin, other proteins, phosphates, sulfates, and organic acid. There are numbers given, that is milliequivalents. And if I subtract the unmeasured anion from cation, that is 23 minus 11, roughly your anion gap will be 12 plus minus 4. But we do not calculate this way. We extrapolate to this case, concept of sodium as a net cation and chloride plus bicarbonate as net anion, and yet the difference, despite not measuring these unmeasured anions, would come to same 12 plus or minus 4. So this is the representative format of anion gap. These are the anions which are not measured, and that's why that gap comes. And the value, if I take the net cation and net anion, that is sodium, chloride, and bicarbonate, it will come 12 as your anion gap. So if these unmeasured anions are high, it is high anion gap. So automatically it will mean there is metabolic acidosis, because high anion gap would mean that these are the agents which are already in excess. They have already utilized bicarbonate relatively, and the bicarbonate is low, and that will go to metabolic acidosis. And if there are low unmeasured anions, that means bicarbonate is not utilized and it is remained there, and that will be low anion gap metabolic alkalosis. So the concept of anion gap is just to know the rough etiological issues related to metabolic acidosis and metabolic alkalosis, and that's how it is more like mathematical application and clinical evaluation. So when you have high anion gap metabolic acidosis, these are the causes, that glycols, lactate, then aspirin, salicylates, renal failure, ketoacidosis, they will all give rise to high anion gap. The normal anion gap metabolic acidosis. Now, if you recollect this definition, that there is sodium minus chloride plus bicarbonate, and I'm already labeling it as acidosis, that means bicarbonate is low, and yet if anion gap is normal, that means chloride has to go up. So sodium is 138, chloride is 110, and bicarbonate is 24. But if 24 has become 16, unless your anion goes up from 110, chloride goes from 110 to 116, the gap would not be normal. But I'm labeling it as normal anion gap metabolic acidosis, which means it's hyperchloridemia related metabolic acidosis. And those conditions are hyperalimentation, acidozolamide, renal tubular acidosis, diarrhea, ureteropelvic shunts, post-hypocapnia, spironolactone. These are the situations where you will get normal anion gap metabolic acidosis. So whole utility of this equation is to find out the etiological factor. And of course, then we have some formulae by which we can know whether it is a single disorder or a double disorder. That means either it's metabolic acidosis alone, or it's a mixed disorder with metabolic alkalosis. So in metabolic acidosis, I can calculate the expected value of PCO2. In alkalosis, I can also calculate the expected value of PCO2. In respiratory acidosis, I can calculate the expected value of bicarbonate, and I'll see both are matching or not. If for one mechanism the other value is matching, then it is compensated. If not matching, it is not compensated, or it becomes a double disorder. So, who is at risk for metabolic acidosis? A high fat diet, low in carbohydrates, kidney failure, being obese, dehydration, aspirin or methanol poisoning, having diabetes, smoking, and alcohol. So, if you now scan many of these etiological factors, is almost sounds like lifestyle disorder. So the lifestyle disorders which we normally see, or we now see, there's a upstream of these cases in the recent time. Maybe they are also the same risk factors for metabolic acidosis. So when someone who's consuming alcohol, or is a smoker, or is on high fatty meal, and that is why the diet would play a major role, because all these substances are hazardous. And once if you have a proper diet plan, probably you can combat acidosis even by diet. Of course, you have to find out the etiological factor, treat them, but this will also go a long way. And that is the second part of our talk, where how dietary adjustments can create some rescue therapy for metabolic acidosis and can go a long way for the healthy individual. So, signs and symptoms, everyone knows that if there is acidosis, they'll get headache, BP will drop, potassium would go up, there will be muscle twitchings, there can be nausea, vomiting, muscle tone drops, they would have Kussmaul's respiration, which is a hyperventilation type of breathing, and there'll be feeble pulse and so many other symptoms. But acidosis is one condition which can damage the body from head to toe and can result into multi-organ failure. And just whatever we have mentioned so far, we do ABG, we do venous blood sampling, calculate all those ions like sodium, potassium, chloride, bicarbonate, try to measure the anion gap. Sometimes urinary studies are done like urine pH, urine ketones. Then we have osmolar gap, which helps you to know about what is happening to sodium and other ions, which are also part of your anion gap. And then find out the appropriate compensatory or non-compensatory mechanisms. Now, the last 5 minutes, I'm going to talk about CKD and metabolic acidosis, because metabolic acidosis is, in fact, one of our primary presentation in CKD, and the incidence of acidosis is nearly 15% of all CKD population, and that is defined when the bicarbonate is less than 22. Acid base balance, we know that there is an input of acid and the output is affected, mainly the kidneys here we are talking about. So all that mechanism which we mentioned, that in proximal tubule, along the nephron, thin ascending limb and collecting duct, the handling of either HI secretion, the ammonium formation, or the phosphate buffer, they are defective, and that is why the reclamation of bicarbonate is also not proper at the proximal tubule, and that is all the mechanisms combining to result into more acidosis. In fact, acidosis also doesn't develop in the first immediate CKD stage. As your CKD stage expands from stage 1 to stage 5, there is more and more acidosis. So initially you will have normal acid-base balance. Then there will be eubicarbonatemia. The bicarbonates would be normal. Then there will be non-acidemic hypobicarbonatemia. That means the bicarbonate is low, but the pH is still maintained by other compensatory mechanisms. And finally they fail, and your bicarbonate becomes low, pH also becomes low, and then there is true acidemia. And that is the area where there will be more progression of CKD and more complications seen. In fact, the decreased GFR with H ion retention can give rise to itself many more changes in the body. Then once there is H ion retention, the interstitial fluid of kidney, the pH drops, the renal tubular pH also drops, and that itself can give rise to generation of variety of pro-inflammatory cytokines, chemokines, angiotensin 2, aldosterone, endothelin, and that all can give rise to interstitial fibrosis. That's why I mentioned that when there is more acidosis, load is more on the medulla of the kidney or tubules in the kidney, and they cannot handle more and more acidification process, and they themselves get damaged in the process. Similarly, there is a adverse effect on the muscle, because once there is H ion retention, there is decreased muscle pH. Then there is upgradation of glucocorticoids, which are more catabolic. Pro-inflammatory cytokines accumulate. Then insulin-like growth factor signaling also drops. There is more insulin resistance, more muscle protein degradation, and muscle wasting. So these are all the hazards which we see. There is also effect on the bone, that if your H ion retention occurs, there is decreased pH of interstitial fluid of the bone. That can increase PTH release. Vitamin D becomes ineffective on the bone. Dissolution of bone mineral, bone formation decreases, and there is osteomalacia or osteitis fibrosa cystica, which we call it as CKD BMD or bone mineral disease. And if the GFR drops and there is acidosis, because of all these aldosterone, endothelin, and pro-inflammatory cytokines, there is progression of CKD. So there is CKD that leads to metabolic acidosis, and metabolic acidosis further progresses CKD. Apart from that, it can damage bone, muscles, hormones, insulin resistance, and can worsen diabetes and so many other mechanisms. So that's why it's important not to allow them to be acidotic. In fact, we have just mentioned the same, that bone demineralization, muscle mass, insulin resistance, the net acid generation milieu also increases, and that itself causes RAS activation, renal damage. In fact, there was a study where a faulty diet, where there was a low grade acidotic milieu created, and then they saw that in because of this faulty diet, that low grade metabolic acidosis is due to lot many end organ damage, that they again saw nephrolithiasis, worsening of diabetes, high blood pressure, and the excessive consumption of acid precursor food, mainly the sources of phosphorus and proteins, which were found to be detrimental because they also could not have enough bases as the neutralizing agent, that is potassium, calcium, or magnesium, and that resulted into more acid base balance volubility, and that resulted into more end organ damage. So that's how a faulty diet can also worsen metabolic acidosis, especially when you have more consumption of acid precursor and less consumption of base precursor. This was the study where they saw that metabolic acidosis associated with cardiovascular events among CKD patients, and they found out that all the cardiac events, myocardial infarction, ischemic stroke, incidents of heart failure, and CV death, all were significantly higher in CKD with metabolic acidosis, and just correction of 1 milliequivalent per liter could result drop in the hazard ratio of all the parameters. That's why it is important to keep correcting acidosis in CKD so as to prevent CVD, that is cardiovascular disease and cardiac mortality. Now, the last part is alkali supplementation. Of course, it's important because when you have more renal compensatory mechanism, as we mentioned, there is decreased interstitial ammonium, increase pH in the medulla, tubular H ion secretion also drops, and all those compensatory mechanisms can give rise to more acidic milieu and more damage to the self itself. So compensatory mechanisms are good, but they are, if excessive, then they can result to more renal damage. And in fact, when you try to correct it with alkaline treatment, not that everything improves. There is improvement in endothelial function, inflammatory status, BMD, that is bone mineral density, muscle mass, all that would improve. The blood pressure won't improve. The various pro-inflammatory cytokines don't drop. In fact, there is worsening of vascular calcification. There is FGF23 and serum phosphate upgradation, and that's why even alkali treatment is not foolproof. And when you talk about alkali treatment, what you would give is bicarbonate, but that is sodium bicarbonate, and almost 600 milligram of sodium bicarbonate will add 500 milligram of sodium per day. So already in a CKD patient, when you give lot of sodium, there will be volume overload, hypertension, weight gain. So these are the issues. And if I give alkali in the citrate form, then the citrate results to more aluminum absorption, and there is acute aluminum encephalopathy. So even the alkali therapy is hazardous. And in this situation, there will be almost a limitation for a drug correction of acidosis, though it is extremely important in CKD in order to prevent the CKD progression, the bone blood density changes, and so many other complications we stated. And that's why it is extremely important to have the diet plan, and that goes with limitations of the drugs. And when you combine the two, then probably you'll get the best results. So that is what we wanted to talk about, this metabolic acidosis. And now I'm handing over to my next speaker, but I'm sure that they will do justice to the dietary plan, and whatever are the limitations or the concepts which you probably cannot cure in our CKD population with just drug therapy, diet would probably go a long way in order to improve it. Thank you, and we'll be open to all questions if there are any.
So, Pooja, are we going to have questions for Dr. Mukesh Shetty now?
Sir, right now we do not have the questions in the question answer box.
No,
So
I can ask some questions so that just to discuss.
Yes, sir. Yes, sir. Please go ahead, sir. We can have the questions for Shetty sir right now. And then we begin with Chitra ma'am's presentation.
Okay. So just a few practical points, I think, for the benefit of whoever has joined. I think he has already told us about the importance of correction of metabolic acidosis, and he has also told us about the basic physiology of acid-base balance, and then what happens in renal failure. Two or three important points. One is I want your opinion on, as practicing nephrologists, we are targeting bicarbonate levels. And you know that whenever a patient comes to our clinic, we are looking at the bicarbonate and then readjusting the doses of the alkali which we are giving. So one important message would be that you should target the bicarbonate. But while you are doing it, what about the sodium load which we often encounter? So what is your opinion regarding that?
Yeah, that's why I showed that even 600 milligram of one sodium bicarbonate 3 times a day would basically add sodium by almost 500 milligrams. That is half a gram. We normally say that we should not take more than 2 or 3 grams of salt diet in order to control their hypertension, where 1/3 of that sodium would be contributed by only our therapy. And that is why naturally sodium bicarbonate, whenever we use, you have to, prior to correcting acidosis, just assess the ECF of the patient, because sodium bicarbonate is going to expand the extracellular fluid volume. So all those patients with poor ejection fraction, already prone for volume overload, they are having low GFR and probably are on the verge of getting dialysis. One aim is of course to retard progression by correcting acidosis, but on the other hand will be pushing them into fluid overload. So one, that it should curtail down the other element of sodium, because there is education to be given that some sodium you are already ingesting by our tablet, and control your volume, then probably acidosis correction without any volume overload would benefit them. Otherwise, I'm sure they will get landed up with full overload or worsening of hypertension just because of the therapy.
So a lot of research is going on regarding changing the salt of the bicarbonate. And ideal salt would be, of course, either you can combine it with calcium or some other salt instead of sodium. However, that has not been successful commercially. Of course, calcium carbonate tablets are available, but the bicarbonate which is released from calcium carbonate is minuscule. So we are looking at some other salts which can be prescribed instead of sodium bicarbonate, but that has not been successful. So right now that remains a concern. So when it is the nutrition advice which is given, we must not forget about the sodium issue. But at the same time, if you don't target the bicarbonate to a desired level, then obviously you will have chronic subclinical metabolic acidosis. And we already know about the long-term effects and the morbidity which is related to chronic subclinical metabolic acidosis. So it's a very important component of therapy for both bone health as well as so many other parameters which go haywire as far as patients of CKD are concerned. And the second issue is, of course, the tablet load. So there are sometimes a lot of people, they require so many tablets, and patients are all the time complaining about the number of tablets. So do you know of any preparation where sachets are available of sodium bicarbonate?
Yeah, so there are sachets available now. There is a new format in the form of liquid also, that you consume around 15 ml, and that will provide nearly 1 gram of sodium bicarbonate. So there are of course different aspects of oral now available. In fact, 2 gram is the concentrated sachet also being created by some companies, especially for pediatric population, because in RTA they require a lot of bicarbonate support. And in pediatrics, so they could not give that 1 gram of tablet multiple times, so they gave 2 grams as sachet.
Right. So alternative preparations are available, but to my mind, this bicarbonate therapy is still needs to be optimized, and we still need to do some better job as far as therapy is concerned. And sometimes the number of tablets required is very, very high, and that is definitely a matter of concern. And of course, we would like to hear from the our dietitians and nutritionists that whether we can increase the bicarbonate naturally by some mechanism, by some dietary modification. That I think we'll hear in the next talk. So over to you, Pooja.
Thank you. Thank you very much, sir. So thank you, Dr. Shetty, sir, for a wonderful academic feast session. And thank you, Dr. Chafikar, as well for the good question, so that our audience had the nice information and inputs on your end. So we thank you both. And now we're looking forward to Dr. Priya Chitra ma'am's session. Pradipta, requesting you to put up ma'am's introductory slide, please. So we have speaker with us, Dr. Priya Chitale ma'am. She's a clinical dietitian and head department of dietetics and nutrition at Apollo Hospitals, Indore. She has a work experience of over 2 decades, and she has many additional qualifications. She has done a course in palliative care medicine from Trivandrum Institute of Palliative Medicine. She is a certified master trainer for diabetes education and training. She is a certified lactation counselor, certified renal nutritionist, and she is certified professional for hospital infection control. She's done SPEN LLL certification on liver and pancreatic diseases, GI diseases, and metabolic syndrome. She's done certificate course in clinical research also. She's awarded amongst 13 most influential personalities by Brijbhumi Foundation for Health and Awareness. She has the professional memberships of Indian Dietetic Association. She's a life member to IPAN India, Diabetes Educator Association. She's a committee member at India Association for Parental and Enteral Nutrition, Indian Pediatric Core Group. She's a vice president of Vigyan Parishad Prayag MP chapter Indore. Ma'am has many publications also to her credit. She has paper publications. She's contributed in the published books as chapter and valuable content in nutrition. She has contributed as a subject expert for newspapers and columns, as well the radio content. NHED-based Android application and booklet for assisted nutrition counseling. So we welcome you, ma'am, and looking forward to your session. Over to you, ma'am.
Thank you so much, Pooja ji, for this introduction of mine. I'll not take much of a time. I hope my screen is visible and I am audible.
Yes, ma'am, you're visible and audible.
Great. At the outset, would like to thank Himani ma'am and Safekar sir, along with IPAN Nashik chapter, Pooja ji, and True Healthy for the opportunity. Would also like to thank Mukesh Sate sir for his for making us understand the medical aspect of metabolic acidosis. These patients usually come to us when we have to do the nutritional assessment in ICU. They are normally not the ward patients. So the agenda for today would be metabolic acidosis to understand from a dietitian's perspective, effect of metabolic acidosis, though sir has covered it, but from our aspect, I would just highlight few points and the dietary perspectives. So as sir has already shared this, the building up of acid in the body due to kidney malfunction or disease or failure. It is the inability of body to either get rid of excess acid. Body is either secreting too much acid, and the inability of the body to balance the acid in the system. Clinical disturbance characterized by an increase in plasma acidity, indicator of an underlying disease process. So it is not an acute condition, it is probably a chronic state, prolonged condition. Important to identify the underlying condition to initiate appropriate therapy. So to reiterate, patient may be presented to us with muscle weakness, muscle twitching and protein energy malnutrition. Kusumal breathing is an abnormal breathing pattern characterized by rapid deep breathing at a consistent pace, probably due to compensatory hyperventilation. Patient can complain of headache and low blood pressure. He can be presented with warm, flushed skin due to vasodilation, may be presented with nausea and vomiting. So the nutrition aspect or the intake must be compromised during that time. There can be a dehydration and liver failure due to decreased bicarbonate production. Diarrhea and fistulas can be present, and there can be a confusion and drowsiness with a lower reflux. With regard to kidneys, metabolic acidosis has been identified as an independent risk factor for the progression of CKD. Kidney has an important role in regulating the acid-base balance. That's what Sir just shared. Metabolic acidosis is common in chronic kidney disease, but also be presented in case of DKA. Metabolic acidosis can lead to poor outcomes such as bone demineralization, muscle mass loss, and worsening of renal function. That's what as a dietitian we normally look for. According to the 2020 Karaoke guidelines, besides the pharmacotherapy, the nutritional treatment plays a pivotal role in the management of CKD. Now, why this needs to be treated? Given the association between metabolic acidosis and pathologic process such as bone demineralization, muscle proteolysis, insulin resistance, poor ability to counteract net endogenous acid production, faster CKD progression, and increased mortality risk, it is of utmost importance to find effective ways of controlling this condition. The much of the work is done by the consultant when the patient is in the ICU at initial level. So when this topic was shared to me, I had to find out what exactly, as a nutritionist, what points we have to consider. So I have shared quite a few reviews and paper publications. So this was a review from Brazil, published in 2017. This states that diet-induced low-grade metabolic acidosis and clinical outcome. This says that consumption of acid precursors food, that is source of phosphorus and protein, to the detriment of those precursors of bases, sources of potassium, calcium, and magnesium, lead to acid-base imbalance. If this condition occurs in a prolonged chronic way, low-grade metabolic acidosis can become significant and predispose to metabolic imbalances. So they say, the review quoted a low-grade metabolic acidosis when the pH is balanced at value close to lower limit of 7.35, associated with impairment of bone metabolism and an increased risk of number of chronic non-communicable diseases such as type 2 diabetes and hypertension. The nutrients that release acid precursors into the bloodstreams are phosphorus and proteins. Most often they are from the animal origin except the beans and nuts, and the foods that are precursor of base are mainly those of plant origin. The study says that metabolic acidosis can be treated with an increased fruit and vegetable intake and oral alkali supplementation. Prolonged and chronic low-grade metabolic acidosis may become significant and predispose to disease. So the review suggested the consequences of dietary-induced low-grade metabolic acidosis may predispose to various disorders, as suggested by Satisar also, and the review also says the same. So nutritional therapy is an adjuvant to pharmacotherapy in the management of metabolic acidosis. Again, one of the study review from 2017 from Australia. This study is about stirring the pot. Can dietary modification alleviate the burden of CKD? The benefit of plant-based diet, naturally high in potassium and fiber and low in acidogenic proteins and minerals, would outweigh the potential risk of developing hyperkalemia in early CKD. They have selected stage 4 CKD patients with a low risk of hyperkalemia, treating metabolic acidosis with base-producing vegetables was effective in improving metabolic acidosis and reducing kidney injury. We understand with CKD, we have to be very cautious with the electrolyte imbalance. However, they also concluded that a larger long-term trials in CKD patients investigating plant-based diets on renal biomarkers and clinical outcomes are necessary based on the positive findings. The same review also talks about the mechanism of dietary factors and their impact on chronic kidney diseases. A very low protein vegetarian diet has also been noted to reduce metabolic acidosis in a cohort of CKD patients. Fruits and vegetables are source of dietary alkali, and intervention to increase fruits and vegetables in CKD population have been shown to increase plasma CO2 levels, indicative of improvement of metabolic acidosis. So the another review published in 2021 from Italy on nutritional approaches for management of metabolic acidosis in CKD suggests a nutritional therapy. They have quite a long list what as a nutritionist we should be considering. It talks about alkali treatment of sodium citrate or sodium bicarbonate, as Sir said, but this is not free from side effects as well. Implementation of a targeted nutritional therapy for the control of metabolic acidosis with CKD is important. A nutritional therapy has a range of additional benefits such as lipid profile control, increased vitamins and antioxidants intake. Diets such as Mediterranean diet, which is alkaline diet, the low protein diet, and the vegan low protein diet can be helpful. The review talks about dietary precautions as well. Stabilizing metabolic acidosis help to preserve muscle mass and to improve bone metabolism. The first thing as a dietitian in the ICU setup, we try to figure out and help how we can help the patient and not go into catabolic states. Eating fruits and vegetables containing alkali or targeted nutritional therapy can be used. They suggest that apple, oranges, and other spinach, tomato can be provided as alkali containing fruits or vegetables. However, since patients with CKD are at risk of developing hyperkalemia, caution is required when consuming fruits and vegetables, and that's the reason why we have to monitor the electrolyte levels every now and then in the ICU. An alkaline diet for CKD patients need to be planned according to the potential renal acid load and potassium quantity of different foods. In addition, a vegan low protein diet can be administered. In this case, it is important to eat cereals or legumes for the intake of essential amino acids. As I said, this review has a lot of information on diet. It also says that high citrate and malate in fruits and vegetables induce an alkalizing effect with decreased hydrogen ions. Plant proteins usually contain high amount of glutamate as compared to animal proteins. Animal proteins in cereal contain sulfur-containing amino acids that oxidizes to produce sulfate, a non-metabolizable anion that determines the daily acid load. In meat and eggs, the content of these amino acids is 2 to 5 times higher than that of grains and legumes. Phosphates and chlorides found in animal products are potent anions in potassium, making these nutrients more acidic than fruits and vegetables. They have the same review has categorized different foods based on pH. So the potentially acidic foods are from the protein group: meat, fowl, fish, shellfish, egg, and all types of cheese, peanut butter, and peanuts. From the fat exchange system, it is bacon, walnut, pumpkin seeds, sesame seeds, sunflower seeds, creamy salad dressings. They are considered as acidic foods. Carbohydrates, all types of bread, including oats, macaroni, wheat, specifically gluten, sweets, gelatin, desserts, and puddings. Based on pH as potentially basic or alkaline foods, from the fat group, dried chestnut, oak nut. From the vegetables, all types of, including legumes, but especially beet, kale, leeks, mustard, spinach, and turnip. Fruits, all types, especially currant, dates, figs, banana, apple, prunes, and raisins. I understand that the potassium content needs to be checked when we are prescribing these fruits, considering the alkaline aspect of it. Sweets, sugars, obviously, if the patient has other comorbid conditions like diabetes, then we have to monitor this as well. Beverages, coffee, considering the restriction on fluid, we have to mix this. Spices, herbs can be used, especially fresh dill, dried spices, as the amount is very small as per the taste. This can be used comfortably. Based on the neutral pH, oils from the fat category, oil and butter are okay. From the dairy, milk is fine. Obviously, phosphate needs to be monitored. From the vegetable source, corn is fine. Sweets, sugar, mostly syrups and honey is okay. And beverages as water and tea. Then the review has detailed explanation on different types of diet. They suggest that Mediterranean diet has the main component of minimally processed plant-based foods, olive oil as principal source of fat, low to moderate consumption of dairy products, fish and poultry is okay, low consumption of red meat and low to moderate consumption of wine with meals. The CKD prevention management were associated with lower risk of CKD in prospective cohort study and RCT with Mediterranean dietary pattern. Then they have moderately restricted low protein diet where the protein intake is around 0.6 gram per kg per day. The relative mortality risk in the diet cohort study was significantly lower in comparison with various dialysis population. They again talk about very low protein diet, containing fruits and vegetables and low amount of protein intake as low as 0.3 gram per kg per day of body weight. Very low protein diet does not slow down the progression of GFR worsening. However, a delayed renal death sparing patients with advanced CKD from dialysis by 1 to 2 years. VLPD is an option for stage 4 to 5 CKD patients with the exclusion of individuals with severe comorbid conditions predisposing to potential hypercatabolic status. In animal models, the VLPD diet has been demonstrated to preserve the renal function by preventing an adaptive increase in glomerular capillary pressure, resulting in progressive sclerosis and excreting an anti-inflammatory action. So a very low protein diet, they suggest that it can be added benefit to the patient with stage 4 and 5 of CKD. Then the most talked about diet is our DASH diet, which is rich in vegetable, fruits, and low-fat dairy products, including whole grains, poultry, fish, and nuts, lower in saturated fats, red meat, sweets and sugars containing beverages, and obviously reduction in sodium. With regard to CKD prevention and management, adherence to the DASH diet was associated with a lower risk of CKD. The DASH diet with 2400 mg per day of sodium restriction had beneficial effects and decreased blood pressure. Then this review also talks about the vegetarian and the vegan diet. We all know as a dietitian, the vegan diets devoid of all animal-derived products. The vegetarian diets devoid of some animal products. It can be lacto-ovo, consuming dairy and egg, Piso consuming fish, egg, and dairy, and semi consuming all but no red meat and poultry. With regard to CKD prevention, vegetarian diet associated with more or less reduction in protein intake have been reported in CKD patients. Moreover, even if the effects of such diet on the progression of renal failure are still debatable, the unquestionably favorable effect on some of the most deleterious cardiovascular and metabolic disorders usually associated with renal failure provide the rationale for recommending a predominance of protein from vegetable sources in CKD patients. This review also talks about Western diet. The Westernization of diet has led to increased intake of animal proteins and decreased intake of fruits and vegetables and overall fiber reduction. The adherence to the Western diet was associated with a higher risk of CKD. Then this review also talks about anti-inflammatory diet. We are all prescribe this diet day in and out. The colorful fruits and vegetables contain a myriad of anti-inflammatory phytochemicals and fiber and are thought to be cornerstone of an anti-inflammatory diet due to their ability to downregulate markers such as CPR and nuclear factor kappa B, histamine, and other inflammatory cytokines in vivo and in vitro. With regard to CKD prevention and management, this needs more evidence-based studies. Another study, which is RCT published in 2013 from USA on a comparison of treating metabolic acidosis in CKD stage 4 hypertensive kidney disease with fruits, vegetables, or sodium bicarbonate. The data indicates that fruits and vegetables improve acidosis and reduce kidney injury in stage 4 CKD without producing hyperkalemia. The acidity and alkalinity of urine are affected by our daily diet. Diet can affect the excreted acidity through the kidneys to maintain the acid-base balance. Diets with animal protein content contain more precursor acid than basic precursors compared to fruits, vegetables that produce more acid in the body than animal protein and dramatically affect CKD and its progression. They have the measurement used in literature in estimation of the dietary acid load. They have the method, the data needed were also being given, the calculations were shared on how we can calculate. They have given the strength of that particular method and the limitations. So it is EAP, then just a gastrointestinal alkaline absorption, how we can use these parameters or tools or methods to evaluate the dietary acid load. Then they have given net endogenous acid production, potential renal acid load, and excretion. So here I have only given two methods for an easy understanding. This is dietary acid load, acid generated from consuming food. Probable renal acid load calculated on intestinal absorption rate of 5 nutrients, including protein, potassium, phosphorus, magnesium, and calcium. Reduction of dietary pral also shows a promising role for the prevention of the metabolic diseases. Dietary acid levels are determined by net endogenous acid production, where the total amount of protein and potassium consumed is considered. Both PRALN and EAP may be effective indicators for dietary acid load status in patients with CKD. This is the formula that they have given. With this, I guess from Monday onwards, I'll be also trying to figure out how I can monitor the patient's condition for PRAL. So PRAL is the formula they have shared is 0.49 into total protein in grams per day, then 0.37% of phosphorus, then 0.021 of potassium, magnesium, and calcium. This is based on the dietary recall of the patient or the diet that we are prescribing to the patients. If the PRAL value comes as negative, that is, an alkaline diet was defined by the total PRAL value less than 0 milliequivalent per day, and the positive PRAL value, the diet is acidic if it is greater than or equal to more than 0.0 milliequivalents per day. So to the prevention and treatment of chronic metabolic acidosis should be comprehended by dietary modification, because the high protein content of the usual diet contributes an increased proportion of acid equivalents. The primary goal of dietary treatment should be to increase the proportion of fruits and vegetables, obviously in consideration with the electrolytes, and to monitor the daily protein intake up to 0.8 to 1 gram per kg of body weight. A tailored nutrition approach should be considered as a valid therapeutic alternative to counteract metabolic acidosis. Thank you so much.
Thank you so much, ma'am, for a wonderful session on the dietary management part of metabolic acidosis.
Thank you.
Ma'am has shared many clinical reference papers also and well explained the importance of diet with the vegetarian, vegan, and the different aspect. I guess the topic is really interesting, and many things we have understood. The formula for PRAL also. Hope we are able to go. We are going to be trying to implicate in our practices. Ma'am, there are a few questions in the question box. I'll be reading out. The question from Ms. Rashmi Srivastav. Suppose a patient with CKD is having potassium level of 4.5. How many fruits would you suggest in stage 1 and stage 5? And would you suggest alkaline fruit juice or coconut water to such patients?
See, based on just 4.5, I'll not be restricting the fruits that are low in potassium. So a serving or 100 grams of apple or a papaya is fine. With regard to fruit juice and coconut water, obviously we have to monitor the fluid intake that is being suggested. Output needs to be monitored. Again, as electrolyte is a daily basis, it changes. So evaluation based on that and prescribing a diet based on that is more appropriate. So it cannot be just one instance. If the potassium is 4.5, I'll be not giving the fruits and vegetables. But if it is a frequent episode, then we need to monitor how much the patient is being given.
Thank you, ma'am. And the next question from Savrashri Saha is, which source of protein is good at this condition? Plant-based or animal-based?
I think I'll have to take Mukesh sir's help as well, because the entire review says plant-based more.
Yes, ma'am.
Again, as a dietitian, we know good quality proteins are also important. So probably adding milk instead of directly adding chicken and meat should be restricted. Sir, I'll request you if you can just help us out on that.
Yeah, so
Sheti sir,
basically,
you are
yeah, animal proteins, of course, are likely to worsen the progress of the patient, and everyone says about plant-based. But our dilemma is something different. All throughout their CKD journey, what we see is that they are malnourished. The
Yes,
malnourishment starts right from stage two,
right,
and though we say that it should be LPD or BLPD, they hardly our patients even reach up to LPD level in their normal diet when it is not restricted. So
right.
we have now created an approach that first you see what is their dietary recall of protein, and in case it is already low, then we do not bother them saying that so many proteins we should not eat. Some people are used to plant proteins; we are happy because that's more safe. But those who are not, and then there are people who now only consume animal protein, we actually tell them that you restrict because that's likely to be more harmful, like red meat, etc. And try to change it to pulses and milk protein because that is more safer. Some who agrees continue, but some would say, we just can't tolerate the vegetarian proteins and we are used to. Then of course we said that you cut it down because that is usually associated with more worsening of progression. But the whole dilemma is whether protein restriction and what stage. Because malnourishment is bigger element than their progression with protein intake.
Very true, sir. So that's why planning and balancing and prescription of a diet from a qualified nutritionist is important.
Right. Yeah.
yes, ma'am. So there's one question which is asking how coffee and tea is considered as basic and neutral in nature.
So that was the study that they have shared. So again, quantity should be limited. That's what I can give from my side.
And Renu Srivastava wants to know the dialysis patient's protein intake per day.
Yeah, in fact, see what happens is during CKDs, everyone has bombarded them about low protein intake so that their creatine should not go up, and they forget that they are already on dialysis now, and that's why most of them would get malnourished because their protein intake is too low. The ideal protein intake recommendation is 1.5 gram per kilogram per day if they are on dialysis, because you have to now add more proteins considering their catabolic process on dialysis. But as I told you that the actual observation is not more than 5% people must be adopting that diet, and most of them continue to take zero point 0.6 zero point 0.8 gram, which on dialysis becomes hazardous. And then the one who is coming walking to dialysis, soon we see that he's now taking help of wheelchair. So every time bombarding that you have to now forget about protein as the enemy and start adopting more protein diet is usually the approach by us when we take our dialysis rounds.
So we also
Yes,
in
thank you,
normal
sir.
practice with dialysis patient, we give, we actually prescribe, but how much patient is following is another story. They have their misconception from everywhere.
Right. Yeah.
Uh, so it's a very good feedback from our audience also today. Many questions coming in. So one more remains to answer is, can we give potatoes to these patients?
See, if patient is on dialysis and his parameters are normal, we normally do not restrict. again, looking at the if there is diabetes or anything, then we have to see his sugar parameters also and see to it that glycemic load of the food needs to be handled well.
Yes, ma'am. So thank you so much for all the question answers also. Uh, we really had a wonderful session today. I am not sure whether more questions are pouring in or so, but for now, I guess, yes, all the questions are covered. Our participants are happy and satisfied to have the answer from the experts like Dr. Shetty and Dr. Chitray. Thank you so much for being with us today for this session on metabolic acidosis. And this was wonderful. Participants were also present for the whole session. We thank Dr. Shete, Dr. Chitray for valuable time given to us. So now to conclude this program, I'll be happy to thank Renal Nutrition India Core Group, IPAIN Nasik chapter team, Dr. Chafekar sir, our own Dr. Chafekar sir, who's always available to help us in whatever sessions we want to plan and execute. Ms. Himani, our chapter secretary, True Healthy team for their very valuable technical assistance in the planning and program. Thank you everyone who's attended the program today, the sessions today. I hope it has benefited everybody. So thank you all, and we conclude the session here. Thank you, ma'am. Thank you, sir.
Yeah, thank you all for
Thank
the
you.
invitation and IPN group. Thank you.
Thank you and goodbye.
Thank you so much. Thank you.